Bismillahirrahmanirrahim. My name is Dr. Ataul Ahmad. I am postgraduate resident of Ophthalmology Department at Mishtar Hospital in Bhutan. Today my topic of presentation is thyroid eye disease management. The learning outcomes of this presentation or session will be: we will have a brief introduction about what is thyroid eye disease, what is sign and symptom of thyroid eye disease, and investigation. These three topics were discussed previously by our colleagues. Just we will have a brief introduction of that. And our presentation will be about management of mild, moderate to severe, and post-implementary complication of thyroid eye disease. So, what is thyroid eye disease? Thyroid eye disease is also called thyroid-associated ophthalmopathy or Graves' ophthalmopathy. Because it's also called Graves' ophthalmopathy, the disease most commonly occurs in the thyroid eye disease most commonly occurs in Graves' ophthalmopathy. In 90% of cases, hyperthyroidism occurs in will be due to Graves' disease. The Graves' disease or thyroid proptosis will be both bilateral and unilateral. In this, thyrotoxicosis will be thyrotoxicosis occur due to raised hormones. Graves' disease is the most common form of hyperthyroidism. This disease, thyroid eye disease, most commonly that will be due to thyrotoxicosis. And most commonly, it occurs in women, mostly in the 4th or 5th decade of life. It will be due to autoimmune disorders. The female patient, the females are more prone to the autoimmune disorders. The symptoms that patient will present to us that will be weight loss, sweating, heat intolerance, or palpitations. The patient will have also weakness and fatigues. Other associated disease symptoms, the signs that we will have in the patient that will be thyroid acropathy, which is the clubbing in the fingers, or pretibial myxedema. Thyroid acropathy will occur in the 1% of patients, and pretibial myxedema will occur in the 5% of the patients. And patient will also have tachycardia, and that will be due to overstimulation of the sympathetic nervous systems. And we will have the thyroid acropathy image after. Thyroid function test, we will advise first to the patients. If the patient has a decreased level of thyroid stimulating hormone or raised level of T3 and T4 levels, it means that the patient has Graves' ophthalmopathy, and we will discuss the mechanism of that latter. If there is thyroid stimulating hormone that is normal or low, then additional test should be advised. Treatment option for the thyroid hyperthyroidisms that are carbimazoles, propylthiouracils, and beta blockers. This is the multidisciplinary disease which should be controlled with the other doctors, which is endocrinologists or internists, that should be involved in this disease also. We have discussed about this, that the patient will have proptosis, lid retraction, tearings, extraocular movement restrictions, and diplopia. If there is compressive optic neuropathy, the patient will have color desaturation or decreased visual acuity. And this is the emergency that we have to do some surgical interventions. This is the thyroid acropathy, which is clubbing like disfiguring of the fingers, which is most commonly in the Severity disease occur, but we can also in 1% of thyroid eye disease we can see it. This is the pretibial myxedema, which is the indurated skin of the legs. Lid retractions, scleral show, proptosis, periorbital edema, you can see in this image, and also thyroid enlargement. This is the typical image of the proptosis which has lid retractions and scleral shows. Normally, thyroid, hypothalamic-pituitary and thyroid axis. Hypothalamic-pituitary thyroid axis, from the hypothalamus, there will be thyroid releasing hormone will be released, and that will stimulate the anterior pituitary gland. Anterior pituitary gland, it will produce TSH hormones that will act on the thyroid gland and thyroid stimulating hormone receptors. It will produce T3 and T4 levels. T3, T4 level will stimulate the peripheral tissues, and that will act on that, and that will lead to growth and development of the tissues and increase cellular metabolism. T3 is the more potent, but that is 20%, and T4 is less potent, that is 80%. This T4 can convert in the peripheral tissue to T3 level, to T3. This mechanism, if normally there is more T3 and T4 level in normal person, so on the negative feedback that will decrease the negative feedback on the hypothalamus, that will decrease the secretion of thyroid releasing hormone and also thyroid stimulating hormones. But in the Graves' ophthalmopathy, in the Graves' disease, there will be this circulation will be abnormal, because due to autoimmune disorder, the patient will have autoantibody against thyroid stimulating hormone in the circulations, and that will overstimulate again and again, that will stimulate the thyroid stimulating hormone receptor on the gland of the thyroid. So the patient will have the higher level of T3 and T4 levels. So this circulation will be abnormal. So the patient will have in the Graves' ophthalmopathy TSH level that will be low, and the T3 and T4 level will be high. So for this reason, we have to advise for our patient first, if we are suspecting thyroid eye disease, first we will advise TSH levels. If there is that is decreased, so we will advise another additional tests. About 3 or 4 days ago, one of our patients that has presented to us with mild thyroid eye disease. The patient has just orbital proptosis. The patient has, so there was just conjunctival injections, not other symptoms that I have asked from the patient. Patient didn't have any heat intolerance, weight loss, other things. But one of our colleagues has advised just T3 and T4 levels, free T3 and T4 levels. When the patient showed to me that was normal. So I have again advised that TSH level is so important, so we will decide according to that. Investigation, which was previously discussed on detail by Dr. Adil, other than blood tests are not necessary if the diagnoses are evident. But visual field testing, we can advise if there is compressive optic neuropathy. We can advise that MRI and CT scan for typical finding of the extraocular muscles enlargements. In what will be the typical management, typical findings, that will be the belly should be enlarged or hypertrophied and the tendon will be spared. Like this, in this image we can find, this is the orbital cavity, bilateral, extraocular muscles are enlarged or hypertrophied. So, sir, I will not mistake this again. Coronal view. This is the coronal view. This is the axial view. So the treatment can be classified into mild disease, which is the most patients. Most patient we have to we can manage these patients, and moderate to severe disease and post-inflammatory complications. Number one things in the treatment of the thyroid eye disease, that is the cessation of smoking. We have to advise, because Cigarette smoking is overdrive our sympathetic nervous system, so it can increase the symptoms of the thyroid eye disease. And also we have to refer the patient to internist or endocrinologist for thyroid dysfunction. That should be managed adequately. Radioiodine treatment and short course of steroid should that be we have to start simultaneously. But if we start radioiodine treatment, the symptoms that will be aggravated. So in the mild disease, the patient will have proptosis. So we have to advise for that lubricants. Due to the patient will have dryness, corneal exposure, the lubricant is the first topical drugs we have to advise. And also superior limbic keratoconjunctivitis, for that we have to advise lubricants. And some authorities, they are advising the topical steroid like cyclosporine, which is the immunosuppressive, and also topical NSAID and topical steroid. And also the patient will have periorbital edema. For that reason, we have to elevate the head of the patient with 3 pillows. So that will decrease the periorbital edema. And also for the prevention of the corneal exposure, we can tape the eyelids at the sleep in the night. Another is the moderate to severe active disease. So this is the less percentage of the disease, but the severity will be more. So we have to be careful about this. For the moderate to severe disease, there are multiple systems they have advised. One is the visa system, another is clinical activity score or CA systems. This was managed by the UGOGO, which is the European group of Graves ophthalmopathy. European group of Graves ophthalmopathy. One group is they have advised there are multiple scores and they are eyed in determining of starting the immunosuppressive drugs. There are 7 scores if there complete is 7 score. If you have 3 scores of that, we have to start the immunosuppressive drugs. There are multiple parameters like if the patient has spontaneous orbital pain or gaze-evoked orbital pain and eyelids swelling, that will be due to thyroid eye disease and eyelid erythema. Conjunctival redness considered to be due to active thyroid eye disease and chemosis, inflammation of caruncle or plica. If this is 7 parameters that the patient has, so 3 out of them are present, we have to start immunosuppressive drugs. 2 another parameters that are, for example, you have examined today one patient. The patient has 2, for example, chemosis and eyelid erythema or periorbital edema, orbital pain. But in the next visit, if the patient has a palpebral fissure is 14 millimeter, but again he is coming on 16 millimeter palpebral fissure. So there is increasing in 2 millimeter palpebral fissure. So this is another one point that we have to increase. If the patient has today, for example, 636 vision, or in the next visit the patient has decreased 1 line, so that is another parameter that we have to increase one's scores. This is for the severity. These are the typical patient which has chemosis, inflammation or redness of the conjunctiva, caruncle or plica redness, or periorbital edema. So it is more than 3. This also scleral shock, periorbital edema, proptosis, and caruncle or plica inflammations. So we have to start for this patient immunosuppressive drugs. Another concept is about the Rundle curve. The Rundle curve is said that thyroid eye disease has one active phase which is 1 to 3 years. Another is the inactive phase which is after 3 years. So if we have this is the very severe stage, and we have to adequately manage this active phase, which is from 1 to 3 years. If we have managed this phase of the disease, there will be no need for the surgical intervention of the patient. But if we have not managed adequately, the patient will need at this stage to the orbital decompression surgery, which is the more destructive surgery. Or after 3 years or 1 year, the patient will have the plateau phase, but there will be any sequela of the patients, like the patient will have proptosis, lid retraction, extraocular movement will be restricted. So we have to manage that surgically. These are another images of the thyroid eye disease, which is a moderate to severe thyroid eye disease. Proptosis scleral shows this is before treatment, after treatment. These are also before treatment, after treatment, and this is the severe stage. Pharmacological treatment in moderate to severe disease that we have to start, that is steroid. That is the mainstay of the treatments. First of all, we have to start for moderate to severe thyroid eye disease, oral prednisolone. Oral prednisolone 60 to 80 milligram per day. Because we have to start the oral prednisolone, we have to reserve the methylprednisolone, which is the injective form of the steroid. We will reserve that for the if the patient has acute compressive optic neuropathy, we have to reserve for that. If the patient has, in the absence of acute sight-threatening disorder, there is no compressive optic neuropathy, we can advise 0.5 gram per week for 6 weeks. That will be followed by another 6 weeks, which will be 0.25 gram per week. It will reduce the discomfort, chemosis, and periorbital edema within 24 hours. These drugs that we have started, for example, we have started 60 to 80 milligram per day, so we have to taper it, not continuously, because we know that steroid has multiple side effects and adverse effects, so we have to prevent that. It will be discontinued after several months, but low dose steroid should be continued. Sometimes, for the prevention of the adverse effect of the steroid, we have to inject orbital steroid to the orbital cavity, but that occur occasionally, sometimes, because there will be less response. Sometimes we are advising low dose fractionated radiotherapy and also steroid, because if you want to prevent the side effect of the steroid. If there is any contraindication to the steroid, if the steroid are ineffective, we can advise them radiotherapy. So the effect of the radiotherapy will be delayed, and the 40% it will not respond. The adverse effect that will occur if we advise to someone radiotherapy, the patient will have cataract, the patient will have as adverse effect retinopathy and optic neuropathy, and sometimes local cancer it can cause. Threshold for radiotherapy should be very high in patient which has diabetes, or in patient which has that are young patients, because it can cause multiple adverse effects that we have mentioned previously. So in a conclusion, if we say that combined therapy with radiotherapy combined therapy with steroid and immunosuppressive drugs that are more effective than one treatment in high dose, like in steroid, if we advise to someone. If the patient has some other sight-threatening disorder like optic neuropathy, which is sight-threatening, and also corneal exposure, which will lead to corneal opacity, so it should be treated aggressively. So we have to start in these patients methylprednisolone 0.5 or 1 gram for 3 days, then oral prednisolone 40 milligram per day. So when we are starting these drugs, so appropriate monitoring should be started. So at the start of the medication, we have to start LFTs, liver function test, because sometimes due to high steroid, it will lead to liver failure, and also we have to give prophylactic of osteoporosis and also gastroprotective treatment to the patient. If the patient has sight-threatening disorder like optic neuropathy or compressive neuropathy, we have to advise for the patient orbital wall decompression surgery or orbital apex decompressions. If the radiotherapy are ineffective or if the steroid are ineffective, so we have to advise the patient surgery. Another is the post-implementary complication. We have discussed previously in the Rendell curve that has two phases. One is the active phase, which is 1 to 3 years. Another is the inactive phase, which is the after 30 or beyond. So if there is any sequela of the disease, like the patient will has extraocular movement will be restricted, the patient will have late retraction. So we have to advise for that patient some surgery. After active inflammation has been remitted, the patient can be left with cosmetically and functionally proptosis. So the treatment is surgical. Surgical decompression increase the orbit volume. So if we remove one part of the bone, so there will be more volume for the more space for the soft tissues. It will decrease if the approach will be external approach and from the medial wall. For example, if the patient has a proptosis or optic neuropathy in the right eye, so we have to approach from the medial side. If we decompression from the lateral or the lateral bony wall, there will be 4 to 5 millimeter reduction in proptosis. If we are doing two wall decompression, lateral and medial wall, so there will be more space for the soft tissue, and we can prevent from the compressive optic neuropathies. But if we are doing lateral and medial wall decompression surgery, there will be more risk of diplopia. In the 3-wall decompression surgery, we have to do, if we are doing lateral, medial, and also fluor, there will be more improvement and more reduction of the proptosis up to 6 to 10 millimeter. These are some slides for the decompressive surgery. If there is less space, there will be more proptosis to the patient. So we have to, from the external approach, we have to enter the orbital cavity, and we have to remove the lateral bony wall and also the medial bony wall. There will be more space for the soft tissues. This is another endoscopic approach. Areas of wound. These areas that has removed, there is more space for the soft tissues. So these surgery we are doing for the sight-threatening disorder, not in every case. If the patient has is loss in vision, so we have to advise these surgeries. Another is restrictive myopathy. After active phase, the patient will, in the inactive phase, the patient has extraocular movement will be restricted. So surgery is required if diplopia is in the primary case or in the reading case. In the reading case, so we have to advise the restrictive myopathy. So if we are advising to someone these surgeries, restrictive strabismus surgery, the patient will have inflammatory stage will be after 6 to 12 months. Inflammation will be settled, so we can advise after that the surgery. So if you want to, for temporary situation, if you want to alleviate the diplopia, we can advise two things. One is prism glasses, another is botulinum toxins. We can advise for the patient. If we are doing any surgery for the extraocular move, for the restrictive myopathy, we will not do any resection surgery, especially the medial rectus and lateral rectus. We are doing recession of inferior and medial rectus muscles. Or we have to encourage the patient that and stimulate the patient that he will have the binocular single vision like in TV. Another pathology after stable phases, that is lid retraction. In the lid retraction like this, the patient is lid retracted by the doctor also, but the patient will have also lid retraction very severely. So we have to manage like this patient will. Mild retraction it will manage spontaneously, improve spontaneously, but if we control the hyperthyroidism, hyperthyroidism is a condition which there will be overstimulation of the sympathetic nervous system. Due to that, there will be more lid retractions. But also it will be botulinum toxin we can inject to the levator aponeurosis, and also mullarotomy or disinsertion of the mullar muscle, which is innervated by the sympathetic nervous system. We can advise that for the mild lid retractions. In severe cases, if the patient has lid retraction more, so we have to advise the patient disinsertion of levator aponeurosis. So, in a nutshell, if we say that for the management of the thyroid eye disease, for every patient that is coming to us, we have to advise for the patient. We have to refer patient to endocrinologist, restore euthyroidism. If the patient is smoking, we have to advise for the patient to cessation of smoking, withdrawing the smoking, and also we have to advise for the patient in every that is in the mild, severe case, we have to advise the lubricants for the prevention of dryness and exposure keratopathy. So we have discussed this mild thyroid eye disease. These measures should be taken: smoking or local measure, and also moderate to severe. We have to advise glucocorticoids or oral prednisolone. And also, if there is sight-threatening disorder, we have to advise intravenous glucocorticoid, and also radiotherapy, and also immunosuppressive therapy. If there is any sight-threatening disorder, then, for example, like the patient has compressive optic neuropathy, we have to advise for the patient surgical treatment. That is the orbital wall decompression. Thank you from your time and attention. If you have any question.
Dr.
Yes.
आपने while during orbital decompression, you mentioned only one complication of diplopia. What are the other complications you can have during this surgery?
Other complication. Normal, every surgery has some risks. Infection is.
But it's very important to counsel the patient about the possible complications before surgery. So you have to.
You can damage the optic nerve, extraocular muscles.
Inferior nostril nerve होती है उसका damage.
Yes.
जब आप फ्लोर को कह रहे हो तो आप
Orbital.
इंफ्राऑर्बिटल नर्व को डैमेज कर
Yes.
सकते हैं and there could be hypoglobus.
Yes. Hypoglobus. Yes.
Other complication, there are vessels you can damage these vessels and retrobulbar hemorrhage can occur, and due to that, and also due to the soft tissue edema, there can be increase the pressure of orbit, and that can also lead to the optic lesion. And other, you're right.
Doctor sir, is there any effect of treatment of Graves' hyperthyroidism on Grave orbitopathy?
Yes. First of all, in every case of thyroid eye disease, we have mentioned that we have referred patient to endocrinologist because it can decrease from the severity of the disease. And also, if we manage adequately the patient in the moderate to severe stage, which is the active stage, so we can prevent from the orbital decompression surgery. So if we not managed adequately the patient, the severity of disease will be more.
Post-inflammatory phase.
Yes.
Is there any effect?
In post-inflammatory, so
Could it be orbitopathy signs symptoms could be reversed?
yes, we have mentioned in the lead retraction. In the lead retraction, if you have adequately managed the patient, in the patient is euthyroid, there will be no need for any lead surgery because there will be over.
पहले अगर ऑर्बिट पर इन्वॉल्वमेंट हो गई है उस T3T4 नॉर्मल करने से क्या वो सारा रिवर्स हो जाएगा?
रिवर्स नहीं हो जाएगा लेकिन कम हो जाएगा.
Actually, stimulation, overstimulation of sympathetic.
वो तो हमने T3T4 कम किया. Yes, sir, हम पहले अंदर
It's a mild retraction. That is mild due to overstimulation of the sympathetic system. It will get reversed. Otherwise, it will not. You have mentioned the loss of real mechanism in thyroid eye disease, which is compressive optic neuropathy. Another one is due to
Corneal exposure.
If any other mechanism of loss of vision in that is
retinal detachment can occur.
कोई और?
इंट्राओकुलर प्रेशर ज़्यादा होने की वजह से ऑप्टिक न्यूरोपैथी.
What is the mechanism of increase?
सर उसका एक ना सेक्टर साइन होता है, एक सेक्टर साइन होता है, उसमें ये होता है कि इंफीरियर रेक्टस जो मसल है ना उसके सबसे पहले वो मुतासिर होते हैं इंफीरियर रेक्टस मसल. और अगर सुपीरियर केस में वो बंदा देखने की ट्राई करे तो इंफीरियर रेक्टस कंप्रेशन की वजह से नर्व की कंप्रेशन बढ़ाएगा और एपिस्क्लेरल फ्लो ज़्यादा हो रहा है और उसकी वजह से फिर वो ऑप्टिक नर्व कंप्रेशन होगी.
लेकिन ना वेनस ड्रेनेज की ऑब्स्ट्रक्शन से आपके एपिस्क्लेरल वेनस प्रेशर जो है वो बढ़ जाता है, इसकी वजह से आईओपी रेज होता है और आईओपी रेज होने से भी आपका ऑप्टिक न्यूरोपैथी. अदर जैसे हमने मेंशन किया कि आपकी कंप्रेशन की वजह से वो मैकुलर फोल्ड्स बनते हैं, उसकी वजह से मैकुलर एडिमा. दैट आर सम मैकेनिज्म.
When will you prescribe steroid, systemic steroid in thyroid eye disease? Systemic steroid कब सोचेंगे, कब देने?
जब सर कॉम्प्लिकेशन में चले जाएंगे।
कौन सी?
प्रोसेस में
ये प्रोसेस में प्रोसेस में वाइल्ड आई डिजीज का प्रोसेस तो है, उसमें स्टेरॉइड दे देंगे। डॉक्टर तहमीना, अच्छा ये है, आप आपस में बातें करते रहते हैं, पूरी क्लास को सुनाया। डॉक्टर तहमीना वो दरवाजे के पास बैठा है, उसके पास आवाज है, आवाज ना आए तो आपने बताना है भाई।
जैसे डॉक्टर अतान ने हमें बताया कि मॉडरेट टू सीवियर स्टेज होती है ना, उसमें हम स्टेरॉइड प्रिस्क्राइब करते हैं। और इन्फ्लेमेटरी स्टेज होती है, उसमें हमें जो साइंस मिलते हैं, 3 क्लिनिकल एक्टिविटी स्कोर के अकॉर्डिंगली हम देख लेते हैं, 3 आउट ऑफ 7 होंगे। उसमें आईलिड एडिमा है, कीमोसिस है, और या फिर कंजक्टिवल स्वेलिंग है, ट्रंकल की इन्फ्लेमेशन है, और पेन है ऑन मूवमेंट, और इसके अलावा प्राइमरी है। तो उसमें हमें देखना है कि क्लासिफिकेशन करके कि अगर वो इन्फ्लेमेटरी स्टेज में है तो ये साइंस देखते हैं, हम उनको स्टेरॉइड प्रिस्क्राइब करेंगे।
यानी वो जो 7 साइन लिखे थे वो अगर हैं तो सिस्टम स्टेरॉइड दे देंगे। ट्रंकल की इन्फ्लेमेशन है, कीमोसिस, सिस्टम स्टेरॉइड दे देंगे।
सर अगर हमें कंफर्म हो गया है उससे इन्वेस्टिगेशन से रिजल्ट कि है उसको थायराइड डिजीज और इन्फ्लेमेटरी एक्टिव स्टेज उसमें चल रही है, सर फिर हम देंगे उसको
ना भाई, ये होगा तो देंगे, ये होगा तो देंगे, इस तरह की बात करें। ये डॉक्टर महा इतना डिस्कस कर लिया।
सर डॉक्टर तमीना बिल्कुल ठीक कह रही हैं। सिस्टेमिक स्टेरॉइड्स हम तभी देते हैं मॉडरेट टू सीवियर डिजीज में। इसके अंदर जब आपका क्लिनिकल एक्टिविटी स्कोर 3 से ज़्यादा 3 to between 3 and 7 होगा तो तब आप स्टार्ट कर देंगे, वरना अदरवाइज कॉम्प्लिकेशन में जा सकता है। ऑप्टिक नर्व की कंप्रेशन या फिर एक्सपोजर केराटोपैथी से पहले हम आपको सिस्टेमिक स्टेरॉइड्स प्रिस्क्राइब कर देंगे।
अगर राशि क्लोज कर दो फेस को, इंडिकेशन ऑफ सिस्टम स्टेरॉइड।
सर सबसे पहले तो ये है कि स्टेरॉइड हमारे पास मेन स्टे ऑफ ट्रीटमेंट है। अगर तो ऑप्टिक नर्व कंप्रेशन हो रही है या फिर एक्सपोजर केराटोपैथी के, फिर तो हमने फौरन स्टार्ट करना है। उसके अलावा हमारे पास आता है क्लिनिकली एक्टिविटी स्कोर, जैसे ये बता रहे हैं, उसमें जो पॉइंट्स हैं 7 पॉइंट्स हैं। अगर तो मोर देन हमें 3B7 इनिशियल उस पे विजिट पे मिल जाते हैं, या फिर हमने नेक्स्ट फॉलो अप किया है उस पे मोर देन 4/7 पॉइंट्स हैं, तो हमने स्टार्ट करना है। नेक्स्ट हमारे पास आता है वीजा स्कोर। वीजा स्कोर में अगर हमारे पास इनिशियल विजिट पे 4/10 है स्कोर से ज़्यादा है, या फिर नेक्स्ट उसके किसी भी विजिट पे मोर देन 5/10 है, तो हमने स्टार्ट करना है।
अच्छा ये ठीक है आपका जवाब। ऐसे अपना इम्यूनोसप्रेसिव या वो कब देंगे, उनका कब सोचना है?
स्टेरॉइड स्पेयरिंग कह रहे हैं।
Is that your friend?
इसमें एक तो हम सर साइक्लोस्पोरिन जो टॉपिकल हैं, या जो टॉपिकल हैं वो तो हम माइल्ड में भी देते हैं। सेकंड हमारे पास इनको हम कॉम्बिनेशन में यूज करते हैं, इनके रेडिएशन थेरेपी के उनके साथ यूज कर सकते हैं, या फिर हम उसके साथ स्टेरॉइड्स के साथ स्टार्ट।
कब सोचेंगे ना, पहले आपने स्टेरॉइड दे दिए, अब स्टेरॉइड कब सोचेंगे कि ऐड करें?
सर उसमें हम ये देखते हैं कि अगर स्टेरॉइड इनइफेक्टिव है या किसी पेशेंट में कंट्राइंडिकेशन है, फिर हमने उसके बारे में
या उसके सर साइड पर स्टार्ट हो गया
पहले स्ट्राइड पे जाए ना, मैनेजमेंट भी ये रेडियो आयोडीन एंड शॉर्ट कोर्स ऑफ स्टेरॉइड साइमल्टेनियसली, ये किसने देनी है, कब देनी है, क्या इंडिकेशन है इसकी?
Sir, start of the treatment, we can give to the patient short course of steroid both simultaneously. But they have mentioned that radioiodine can increase the symptoms of the thyroid eye disease.
In order to cover that, you would give short course of steroids.
Yes.
So usually we refer the patient to the endocrinologist. He is going to start this radioactive. But you can obviously communicate with him, telling him that this can reverse, this can aggravate our thyroid eye disease symptoms. So kindly start short course of steroid.
Yes.
For the moment you have, you don't start the radioactive iodine on our own.
Sir, the question you have asked, normally we have started moderate to severe thyroid eye disease, prednisolone oral, but the IV steroid we are reserved for the acute compressive optic neuropathy. If there is acute compressive optic neuropathy, we can then start the IV steroid. Normally we are not
IV steroids can be given moderate to severe.
moderate to severe, but we have to reserve that. We have reserved that.
नहीं ऐसा नहीं है, उसमें हम दे सकते हैं ऑप्टिक न्यूरोपैथी के अलावा, और जैसे मॉडरेट सीवियर डिजीज है उसमें भी दे सकते हैं। बल्कि ये भी एक स्टडी देखी गई है कि आईवी स्टेरॉइड्स हैं, इनके रिजल्ट सुपीरियर है कंपेयर टू जो ओरल स्टेरॉइड। अच्छा, ये क्लिनिकल एक्टिविटी स्कोर में ना आप 3 मोर है, ग्रेड 10 है, 7 नहीं है, उसमें आप डिवाइड कर लें उसको पेन, रेडनेस, स्वेलिंग एंड इम्पेयर्ड फंक्शन। पेन में आपको इरेगुलर पेन आ जाएगा और गेज वो पेन आ जाएगा।
We have 7 parameters, so according to that,
3 more scores are added on follow up.
3 out of 7. If there are
टोटल 7 है,
yes,
10 है, 10 में से 3 अगर आपके 3 आर मोर।
3 उसने बताया नहीं है, वो प्रोग्नोसिस का बताया, वो चीज़ें बताई हैं।
2 बताए हैं, एक जो नहीं बताया वो ये है कि रिस्ट्रिक्शन ऑफ मूवमेंट ऑन फॉलो अप. If there is a restriction in any direction 5 to 8 degree, then 1 score more will be added.
जो है क्लिनिकल एक्टिविटी स्कोर, जब हमारे पास पहले इनिशियल विजिट पे पेशेंट आता है उस टाइम उसके 7 स्कोर, और जब हमारे पास नेक्स्ट विजिट पे आता है उस टाइम 10 हो जाता है। उसकी रीज़न ये है कि हमने प्रोपोजल देखनी है, उसकी एक्स्ट्रा मूवमेंट देखनी है, रिस्ट्रिक्शन स्नेलन एक्टिविटी के लिए इनिशियली 7 होते हैं क्लिनिकल एक्टिविटी स्कोर, वीजा के 10 है।
इनिशियल में कैसे दिखता है 2 मिलीमीटर से ज़्यादा, वो तो आया है और सबसे विजिट पे आया है तो पता चलेगा कि पहले उसकी प्रोग्नोसिस से 2 मिलीमीटर
पेशेंट अगर प्रेजेंट ही इस स्टेज पे किया है, जरूरी नहीं कि वो अर्ली स्टेज पे आपके पास आ जाए,
वो तो
उस स्टेज पे आ गया है ना। अब हम फॉलो अप पे ये देखेंगे कि ये प्रोप्टोसिस है ना, ये बढ़ रही है, ये कम हो रही है।
प्रोप्टोसिस को डिफाइन करें आप। प्रोप्टोसिस में लिखा है कि देयर इज मोर देन 2 मिलीमीटर प्रोप्टोसिस। प्रोप्टोसिस हो सकता है कि 20 मिलीमीटर से उसका वेट ज़्यादा है जी, ऑर्बिटल मार्जिन से एबासिस का, ठीक है, या फिर उनके एसिमेट्री है दोनों, तो आप उसको प्रोप्टोसिस लिखोगे या नहीं लिखोगे?
नहीं, उसको लिखेंगे। अब 1 to 3 मंथ फॉलो अप पे आ रहे हैं ना पेशेंट हमारे पास, अब हम प्रोप्टोसिस दोबारा मेजर कर रहे हैं।
वो ठीक है, आपकी बात बढ़ रहा है कि नहीं बढ़ रहा
जी, अगर वो 2 mm बढ़ रहा है तो हम 1 स्कोर और ऐड करें,
1 पॉइंट और ऐड करें, तो इन सब का एक पॉइंट। फॉलो अप पे हमारे पास 3 और पॉइंट्स आ जाते हैं। वैसे हमारे पास क्लिनिकल एक्टिविटीज को इनिशियल विजिट पे 7 है।
thank you, sir.